Welcome to Word of Hope, Ovarian Cancer Podcast, brought to you in partnership with Word and Libby's Hope. For more links and information on this episode, visit wordofhopepodcast.com.
Welcome to Word of Hope, Ovarian Cancer Podcast. I'm Nate Manahan from Women's Oncology Research and Dialogue, and I'm again joined today with Paul Cacciatore from Libby's Hope. Today in episode 5, we are going to be looking at CA125 and recurrent ovarian cancer. This will be a very important discussion as we move forward through these 10 topics of ovarian cancer research and education from 2010. So Paul, why don't you get us started?
Okay, thanks, Nate. The next story, the study appeared in The Lancet, the UK medical journal. And what it dealt with was actually an issue that's become quite lively, I think, particularly among ovarian cancer patients. And it addresses this issue of early versus delayed treatment of recurrent ovarian cancer. And what I mean by that is if a patient has initial surgery and then gets treated, for instance, with chemotherapy in their first-line treatment, hopefully everything goes well and the patient goes into remission. But we also know that a large majority of ovarian cancer patients recur. Their disease comes back. And so the question is once it comes back, well, first, how do you know it came back? And this is a big issue. Most ovarian cancer patients are monitored with a blood test called CA125, stands for cancer antigen 125. And doctors will monitor that, say every 3 months. And what they'll do is they'll look for rises. I think usually they look for 2 consecutive increases of a certain percentage.
If a physician sees these rises, does this mean the patient goes right back into treatment, either chemo or surgery?
It's been a bit of a controversy. And so what this study did is it took a group of women and it looked at CA125 concentrations. Once their concentration hit twice the normal limit, what they did is they randomized then those patients into 2 different arms. One arm is immediate treatment based on that finding, and the other was waiting until the patient became symptomatic to treat them.
So was there a major difference of how these 2 arms responded to treatment?
It was interesting because the study found out that in terms of median survival, there was no difference. They found about a 25-month median survival for the early treatment patients, and they found about a 27-month median survival for the delayed treatment patients. So they concluded that using CA125 to routinely monitor recurrence once a patient goes into full remission after initial treatment, it's just not proven. Meaning, just because you know your CA125 and it's going up, if we go ahead and treat you just based on that, it doesn't seem to change the difference in survival.
Paul, as I've had the opportunity and privilege to talk to many ovarian cancer survivors, nearly every time when I ask them how they're doing, one of the first things they bring up is what is their CA125? Now, does this study mean that they shouldn't be using CA125 as their ovarian cancer follow-up?
This has become kind of a controversial issue. There was a commentary that was published along with this article in The Lancet by 2 U.S. doctors. And they pointed out actually a number of very, very, I think, important points with respect to this study. The first thing they noticed was that in the patients that had been randomized, remember, into the early or the late treatment after they had recurred, their ovarian cancer had come back, 54% of those patients were either platinum drug resistant or refractory. And just so for our listeners and people watching the video, platinum-free interval is a term used in ovarian cancer. It basically measures the time period from your last platinum drug treatment, saying cisplatin or, one of the platinum-type drugs. Measures from that time period, the last administration of the drug, until your cancer comes back. The longer the period, the studies indicate the more treatable the cancer or the more reactive the cancer is to drugs in a beneficial way. And so 54% of these patients had their cancer come back within 12 months. 20% had their cancer come back within 6 months. So these are, again, resistant refractory patients. And so what they concluded in the commentary was these are patients that are going to be difficult to treat under any circumstance. Late, early, isn't going to be much of a difference. And so maybe it wasn't the best group of patients to be, to have randomized and tested.
Paul, this theme just keeps coming up over and over again, that how important it is for patients, scientists, and clinicians to not treat all ovarian cancers as the same diagnosis. There are many subtypes and many types of ovarian cancer. So what was the other point of the commentary?
The other thing they noticed was that so we talked about 54%. The remainder of the patients had a treatment-free interval that exceeded 12 months. Now, we call those platinum-sensitive patients. And what they found out is that out of those patients, only 7% received any type of surgical intervention. Now, keep in mind, you can be in theory, you can be operated on more than once when you have ovarian cancer. And if you have certain conditions in the pelvic region, and a gynecologic oncologist determines it can be operated on, there's a chance to reduce the tumor burden within the woman by going ahead and performing surgery. Well, that's kind of astounding when you think that out of this large group of patients, a little less than half, that had a treatment-free interval greater than 12 months, only 7% received surgery.
Wow, only 7%? That seems really low.
It's a little disconcerting, I think, when you look at that, because the theory would be that had they received surgery, and there's some studies that indicate that if you receive surgery upon recurrence, and you're able to, a doctor makes a determination that you're a surgical candidate, that surgery may in fact provide benefit to you. And so the question now becomes, if you take the general approach that CA-125 testing is irrelevant to measure recurrence because there's no survival advantage, you have this issue of, is the patient a surgical candidate? And have you delayed a surgery because in essence, you weren't listening to or you weren't following this rise in CA-125? Meaning, by waiting, have you made them less of a surgical candidate than if you had done surgery earlier based on the CA-125? And lo and behold, a couple weeks ago, a group at Cedars-Sinai went ahead and they published results for a retrospective study. They looked basically at these secondary cytoreductive surgery, that's the name, where you have that second surgery. They looked at them for a time period from 95 to 2009. And what they were trying to determine was, an answer to this question. Is a patient that is a potential surgical candidate in better shape, by getting to surgery sooner rather than later based on a rising CA-125? And what they found out is they think that that answer is yes. They think that the patients who ended up with optimal secondary surgery, meaning less than 1 centimeter of residual disease left, that it was important that they get to the operating room sooner rather than later. And they found out that the optimal patients basically got to the operating room in about 5 weeks, whereas the other patients, the delayed patients, got there in about 16 weeks. And they also translated that into an overall survival issue, meaning that optimal secondary surgery was associated with a longer survival, 47 months versus 23 months, which is a big difference. And so I think this issue, is going to become big. The other finding they had in that study was that they translated that survival benefit, some of those numbers, into the fact that for each week there is a delay after the first CA-125 elevation, it corresponded with a 3% increase in suboptimal resection when that secondary surgery occurs.
So as of today, Paul, this really doesn't change any of the recommendations for treating and tracking recurrent ovarian cancer?
Well, I think this is going to be a lively issue going forward about, I think most ovarian cancer patients would like to think that they want the CA-125 monitored. But you do have this study indicating there may not be quite a survival advantage, based on just monitoring CA-125 for recurrence. But you also have this surgical issue that's out there saying, if you don't pay attention to the CA-125, is there a chance with a certain select group of patients you may have missed a surgical opportunity to bring them back into a state of optimal cytoreduction or optimal debulking, where there's less than 1 centimeter of cancer left. So I think it's a bit controversial. I'm sure the issue will shake out down the road, but it's an important issue overall.
And I think, Paul, for women that are watching, and that it shows that they're one of the top things still in the fight against ovarian cancer is your surgery and making sure that you get the surgery at the right time. We don't know for sure when that right time is, but that the best treatment right now still, all the drugs that were being created, most of the time is the surgery. And it's really important for them to know when and who is doing their surgeries.
Yeah, you're absolutely right, Nate. There's actually an abundance of studies that show that the single best weapon that we have against ovarian cancer is surgery. And when you combine that with surgery performed by a gynecologic oncologist at a high volume surgery center, it helps even more. Yep. And so there's very little doubt that surgery is a very, very important weapon against ovarian cancer. And I think, in credit to the Cedars-Sinai group, although it is, again, I have to note, it is a retrospective study. So they're kind of looking back in time, and they're trying to make, some mathematical adjustments and assumptions to try to figure this out. But the concept is nevertheless important, that you may not want to make a black and white rule to ignore CA-125 in a recurrent ovarian cancer context if it poses the issue of maybe ignoring surgical candidates. Yeah. And so I think that becomes, that's a very, very big issue. And hopefully there'll be more studies, and this issue will shake out in a bit more detail on hopefully a very good prospective study, looking forward. That would be great.
Paul, great information. An excellent overview of CA-125 and recurrent ovarian cancer. And I hope there's more research for us to discuss very soon. As a listener and viewer of this podcast, I hope that you'll go over to wordofhopepodcast.com, view the links there, follow them, read the articles, and then go back and make some comments. And we want to create some dialogue there on the site. If you have a specific question for us and you want to email us, just click on the Contact Us link, and we'll be glad to get back to you as soon as possible. And then join us next time for Word of Hope Podcast, because we'll be talking about neoadjuvant chemotherapy. It'll be a great discussion as Paul leads us through some of the newest research in this area. Thanks for watching and listening to Word of Hope Ovarian Cancer Podcast.
You've been listening to Word of Hope Ovarian Cancer Podcast, brought to you in partnership with Word and Libby's Hope. For more information on this episode and how to subscribe, visit wordofhopepodcast.com.